Hi everybody, and welcome to our module on perinatal infections. Let's start by talking about maternal HIV infection. So when a mother has HIV infection during pregnancy, placental transmission to the baby may occur. So to prevent this from happening, HIV positive mothers are always treated during pregnancy. And because women can be unaware that they have HIV infection at the time they become pregnant, prenatal HIV testing is standard and recommended by the CDC. The CDC recommends an opt-out approach for HIV testing, and what this means is that women are told it's part of the standard panel of tests, and unless women decline, HIV testing is always performed as part of prenatal testing in the first trimester. As I mentioned on the last slide, all HIV-positive mothers should receive antiretroviral therapy during pregnancy to prevent placental transmission to the baby. For mothers who enter pregnancy already knowing they are HIV positive and on ART with a low viral load, for these women, you simply continue ART during pregnancy. For women with HIV infection who become pregnant who are treatment naive, they should have ART initiated at the time of pregnancy. There are lots of regimens used for this purpose, but usually they consist of what's known as an NRTI backbone, plus either a protease inhibitor or integrase inhibitor. NRTI drugs are nucleoside reverse transcriptase inhibitor drugs. They usually come as a two-drug combo like abacavir and lamivudine, or tenofovir and emtricitabine. Protease inhibitor options are atenazavir or darunavir, and the integrase inhibitor that's commonly used is raltegravir. And usually ART is continued throughout pregnancy and into the postpartum period. Zidovudine was the first HIV drug introduced in the 1980s. It also goes by the name azithromycin or AZT. And zidovudine is capable of crossing the placenta, and it can provide prophylaxis to the fetus from transplacental infection. And in particular, intravenous zidovudine has been studied with administration during labor and delivery, in other words, intrapartum, and shown to decrease the transmission of HIV from mother to baby anytime the HIV viral load, meaning the HIV RNA, is greater than 1,000 copies per milliliter. So at the time of delivery in mothers with HIV, the major decisions are whether or not to allow a vaginal delivery, because those are higher risk for transmission to the baby, and whether or not to administer intrapartum zidovudine. If the mother has a viral load less than 1,000 and she's on antiretroviral therapy, then vaginal delivery is considered low risk, and a cesarean section is usually not recommended, and in these cases intrapartum IV zidovudine during labor and delivery is not routinely administered. If, on the other hand, the mother has a viral load greater than 1,000 at the time of delivery, this is a very high-risk situation for infecting the baby. So usually a cesarean section is scheduled and intravenous zidovudine is administered during delivery. And then after the baby is born, there's prophylactic newborn therapy that is administered. If the maternal viral load at the time of delivery was less than 50, which is very low, then the baby usually gets zidovudine for 4 to 6 weeks after birth. If, on the other hand, the maternal viral load at the time of delivery was greater than 50, then the baby usually gets combined antiretroviral therapy. It's often a 2 or 3 drug regimen for several weeks. Next, let's talk about hepatitis B in pregnancy. So just like with HIV, for hepatitis B, transplacental infection of the baby can occur. And so for this reason, testing for hepatitis B infection by measurement of the hepatitis B surface antigen is always performed at the first prenatal visit for pregnant women. If the baby becomes infected at the time of birth, this very often leads to chronic disease, including cirrhosis and liver failure. So for this reason, all babies receive the hepatitis B vaccine at the time of birth. And I talk about this in more detail in videos in the pediatric section. If a mother is known to be hepatitis B positive, then not only does her baby receive the vaccine at birth, but also the baby receives hepatitis B immune globulin, and it's very high yield to know this for your boards. For hepatitis C, transplacental infection can also occur if mothers are hep C positive. However, transplacental infection is less common than with hepatitis B. Hep C infection of the baby only occurs in women who have detectable hep C virus RNA at the time of pregnancy. In contrast to hepatitis B, there are no interventions shown to reduce vertical transmission from mother to baby of hepatitis C. So the only treatment for mothers who are hep C positive is pre-pregnancy treatment for chronic hepatitis C. Basically, you want the mother to receive treatment for hep C before she becomes pregnant, because during pregnancy there's nothing you can do to limit transmission to the baby. Next, let's talk about chlamydia infection. So maternal infection with chlamydia during pregnancy is associated with a number of adverse outcomes. An easy way to remember this is just to appreciate that chlamydia can lead to early rupture of membranes. And so if you know that, it's easy to remember that mothers with chlamydia infection can develop PPROM, and that can lead to preterm delivery or low birth weight babies. Most women with chlamydia infection are asymptomatic, so all women are screened for chlamydia infection at the first prenatal visit, usually with a cervical swab for nucleic acid amplification testing. When chlamydia is diagnosed during pregnancy, the treatment is with azithromycin. Usually 1 gram is given orally as a single dose. You also have to treat all partners, and 2 weeks out you test for cure to make sure she no longer has chlamydia infection. If the mother has chlamydia infection at the time of vaginal delivery, the infection can be transmitted to the baby. And chlamydia causes 2 major problems in newborn babies. One is conjunctivitis, the other is pneumonia. Conjunctivitis occurs 5 to 14 days after birth, and I talk about this in detail in the pediatrics section in videos on newborns. Newborns are given prophylactic erythromycin eye ointment to prevent gonococcal infection, but this ointment is not effective for prevention of chlamydia. And then chlamydia pneumonia occurs 4 to 12 weeks after birth. About half of babies who develop chlamydia pneumonia previously had conjunctivitis. And babies who get chlamydia pneumonia often start to have respiratory symptoms like cough and nasal congestion a few weeks after birth, and then go on to develop full-blown pneumonia like what's shown in this picture here, about 4 to 12 weeks after birth. To make a diagnosis of chlamydia in a newborn baby, you need to do a swab of either the conjunctiva or the nasopharynx, and then you send it for nucleic acid amplification testing. And the treatment in babies who develop newborn chlamydia infections is with oral erythromycin. Let's talk about gonorrhea. Similar to chlamydia, many women who have gonorrhea infections, about 70%, are asymptomatic. Some women do develop symptoms, and these can include things like vaginal pruritus, which is itching, or discharge, or dysuria. And similar to chlamydia, gonococcal infection during pregnancy is associated with adverse outcomes. So women can develop chorioamnionitis, they can develop premature rupture of membranes, which can lead to preterm birth and low birth weight, and gonorrhea infection is also associated with spontaneous abortions. The diagnosis of gonorrhea in pregnancy is made the same way you make the diagnosis of chlamydia. It's done through a cervical swab sent for nucleic acid amplification testing. The treatment for gonorrhea infection in pregnancy is with ceftriaxone plus azithromycin, and you have to use 2 drugs because resistance is common to single agent therapy. This is in contrast to chlamydia. And then just like we talked about for chlamydia, in women who have gonorrhea during pregnancy, you need to treat all partners and you test for cure 2 weeks after treatment. If mothers have untreated gonorrhea during pregnancy and pass it to the baby, the main problem in the baby is newborn conjunctivitis, which usually develops days 2 to 5, and again I talk about this in more detail in the pediatrics section. For prophylaxis against gonorrhea conjunctivitis, all babies receive erythromycin eye ointment at the time of birth. This is a picture of a baby with this goop in his eye. That's erythromycin eye ointment. And the treatment, if newborn babies develop gonorrheal conjunctivitis, is with a single dose of ceftriaxone, either IM or IV. We'll finish by talking about the Zika virus. This is a very rare infection that's transmitted by mosquito bite. It's most dangerous if pregnant women contract a Zika viral infection in the first trimester. Infected mothers are usually asymptomatic, but the virus can infect the fetal brain, and so babies born to mothers who have Zika virus infection can have microcephaly and thin cerebral cortices. These are some of the classic findings. Also classically intracranial calcifications. And so because of these calcifications that form, a classic finding in a baby born to a mother with Zika virus infection is for the baby to have a closed anterior fontanelle because of calcifications from the viral infection. The diagnosis in a newborn baby can be made through PCR testing of the newborn serum or urine or cerebrospinal fluid. Unfortunately, there is no cure. Treatment is supportive. And the main way you prevent Zika virus infection in newborns is to advise mothers to avoid travel to endemic areas. Shown on this slide is a WHO map of areas where Zika virus is endemic. You can see that it's very common in Central and South America. So pregnant women are generally advised to avoid travel to these areas when they're pregnant in order to avoid development of a Zika virus infection. And that concludes our module on perinatal infections.